We're going to talk today about the realities of trying to make this happen. At the initial discussion, Dr. Neely talked about the large amount of evidence that shows that behavioral health integration works, and it works in primary care practices to make the work that you do more effective. So in light of the fact that there are things that work, the question is, how do you actually make that happen in your own practice and not in a research study? And we spent a number of years working with a large number of practices to try to understand that process, and I'll try to begin to share that with you today. Naturally, there's a lot of information, and I've tried to develop slides that could serve as a reference to you. You'll get a copy of the slide deck after the presentation, and you can look at some of the more complex slides and hopefully use that as a guide. Naturally, in 1 hour, I'm not going to be able to cover everything you need to know, but we're lucky to have NRHI organizations throughout the country that have a similar amount of experience, and we'll help connect you to them if you want to get in touch with us. I'm going to try to illustrate the work that we've done, but before doing that, I just want to touch for a moment on why it's so important. The fact is that a huge number of the patients that we see do have mental health and behavioral health, substance abuse problems. This isn't an additional project. These are the same people we're already taking care of. And the idea of behavioral health integration is to give us some tools and approaches that work more effectively. I hear a lot of stories from the physicians I work with that they've been taking care of patients for years, and it wasn't until they developed a formal approach to behavioral health evaluation that they began to realize that some of these patients who seemed not to be motivated or were poor compliance patients or had all these somatic complaints turned out to be people who actually had mental health disorders that were either not recognized or were not their needs were not integrated into the regular care plan. When we look at the care gap on the next slide, it turns out that this isn't just something that's happening in mental health organizations. This is right in our own practices. And it turns out not only are the people there, but it really influences their care. There are a tremendous number of studies now showing that if you recognize and start to deal with depression, for instance, you start to have reduction of readmissions, improvement of surgical outcomes, up and down the line benefits from reintegrating behavioral health into our practices. So from that point of view, what it means is that we need to prepare ourselves more effectively before we get involved in setting up these programs. It's been a long time for many of our practices since we dealt with these problems, and everyone needs some support.